Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you'll find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
In recognition of our fathers, our uncles, our husbands, our sons, our brothers, lovers, and others, this is Men's Health Awareness Month, and we want to address some of the common concerns that men deal with, especially as they get older. We're going to talk about heart health, prostate health, hormone health, and yes, even the male sex drive, and all the screenings that we need to take advantage of as we get older. This evening's program is underwritten by Tenet Healthcare and the hospitals of Providence, and we also want to thank the El Paso County Medical Society for sponsoring the show to you for over 27 years. I'm Catherine Berg, and this is the El Paso Physician. Thanks again for joining us. Tonight we're going to be talking about men's health. It's make time for your health. A lot of time the mommies and the wives take care of everything, and the men at least have a reputation for not taking care of themselves. I don't necessarily find that to be the truth, but we're going to talk about myths tonight. We're going to talk about a lot of truths tonight. But I'm super excited to have two veterans here with us tonight. We have Dr. Byomesh Tripathi, who is a cardiologist, and then we have also Dr. Javier Arenas, who is a urologist. So thanks again for being here this evening, and we have a lot to talk about. I think back in the day, and I say back in the day, 50, 60, 70 years ago, men didn't tend to take care of their health. But I think that it's something that men are doing a lot more of. I think that we can't escape it because you have advertisements coming at you right and left. You have social media, and then you've got the nagging women. And we are everywhere. And so I will be one of those tonight that are going to talk about health. And so what I'd like to do is Dr. Tripathi, as a cardiologist, and I know it encompasses so many things, but if we're talking about men specifically, I feel like the movement of focusing on women's health has really been up for the last 20, 25, 30 years. But let's go really tonight and focus on men's health. Studies, I feel like, have always been there. A lot of women's studies have just been on the forefront of the news in the last couple of decades. But men's health and cardiology, how is it that you deal with that all day, every day?
Right. So, as you said earlier, we have a lot of advertisement and, focus on women's health, heart problems affecting women. But we have to realize that, a lot of heart problems are very similar in men and women, but there are a lot of heart problems that basically affect men and, women very differently. Mm-hmm. And that can be seen in different aspects. For example, prevalence and risk factors, symptoms, outcomes, and delay in, diagnosis and treatment. So give me a moment to elaborate all that, actually. Mm-hmm. So, talking about risk factors first. So, there are traditional risk factors for heart problems. Those are diabetes, high blood pressure, high cholesterol, and we all know that, right? So in men, they are very, very common, right? It's very straightforward. And those who have it, they are more likely to develop heart problems. But there are certain non-traditional risk factors as well that we need to recognize when it comes to heart problems. And those are stress, depression, autoimmune disease, and menopause, which is not seen in males, right? Mm-hmm. So we have to be cognizant of, the different risk factors that male and females can have, right? So these are the risk factors. And again, we need to know that men are more likely to develop heart problems at early ages compared to females.
And why is that?
So, this is genetic predisposition. There's a lot of longitudinal research that have shown that. Mm-hmm. The other thing that we have now known that male are more likely to develop blockages in the large arteries of the heart compared to females, which develop something called microvascular disease, which is basically blockages in small arteries of heart. Mm-hmm. So That's
And it's just the
something.
biological makeup.
It's
It's not
biological,
necessarily
yeah.
diet. Is it in any way hormone related, testosterone and estrogen? When you look at men and women, immediately that's what people think. Well, it's okay. We'll look at the different organs.
Yeah, I
And
would like to correct one thing. Yes, there's some hormonal component to it as well, because women have estrogen in their body more than males, right? So, an estrogen is known to be cardioprotective, meaning those women who are not in menopause status, they have more estrogen, and that protects them from developing heart problems. So that could be one of the factors. But again, there are some lifestyle, component where male are more likely to, smoke and, do bad stuff compared to women. And then
oh,
there's some
listen to
genetic
him. Men are
component.
more likely to do bad stuff than women. That came from you, not from me. But I had to repeat it. It was great. No, but in general, health. And it's again, years ago, there's a lot more risk.
Yeah.
Men tend to take a lot more risk with their health. And again, I don't know if that's so much today, but at least a century ago, that was
Yeah.
kind of the deal. Dr. Dennis, if we could talk about urology. So that is your specialty. And I kind of want to talk about all day, every day. And I know you do both. But we're talking about male health screenings. And I feel like when people think about men getting screenings over the age of 50, it's prostate cancer. But there's a lot of other things you can screen for too. But in general, when they come to you, I'm assuming that there are other issues that men talk about as well, including heart. And maybe sometimes they only come to see you and they don't go see their internal medicine doctor. I don't know. But I know with women, that's often the case. They go for their annual checkup and that kind of becomes their internal medicine doc. Is that kind of the same situation with you?
I would argue, yeah, to a certain extent, yes. For the most part, a good proportion of men that come into my office have already been referred by the primary care provider.
Okay.
And when regards to screening, most of the time it's a diligent, aggressive primary care provider that's began screening for prostate cancer. And that's pretty much the main one in men for all men. As far as what to screen for from a urologic standpoint, it's going to be prostate cancer.
Okay.
And I'll get men of various ages from primary care providers that have been starting the screening process at different ages. And the recommendations that we have right now is if you're a low-risk patient, no family history, you're not African-American, non-smoker, you're considered low risk. And so you can get screened, or you should start getting screened at 55 years of age. If you do have a family history, specifically a first-degree relative, a brother, a father, maybe even a grandfather, then you may land in the higher risk category. And if you're an African-American male, same thing, high risk category, in which case we recommend age 40 to start getting screened for prostate cancer. And the screening process should entail a blood test called a PSA, which is a prostate-specific antigen or a prostate-specific protein, along with a prostate exam, which is the rectal exam. And that's probably what most men dread the most. But it's very helpful to identify any sort of abnormality.
And if I could stop you there, because I'd like for men that are listening and or their caretakers to understand what is it that you are looking for in the digital rectal exam. What are you feeling for, so that they can, in their minds, think about what it is that you're feeling for and why that's necessary, so that some of that, not fear, the anxiousness goes away, because it's a real reason that you're doing that.
Absolutely, yes. And we're looking for size and symmetry. So the prostate is basically, on the prostate exam, you're feeling two lobes, the left lobe and the right lobe. So you want to make sure that the left side and the right side are symmetric in size. You want to make sure that there's no nodularity. You want to make sure that it's not rock hard. And then at the same time, I'm assessing the size. And so those three things, or the size, symmetry, and nodularity, you can't find that in a blood test. So a lot of men will come into my office and they'll ask me, well, I just had my blood test, and my primary care is checking my prostate with blood exams. And I have to educate them that the blood exam is helpful, but it's in combination with the rectal exam, the prostate, palpating the prostate, looking for symmetry, looking for nodularity. And that's what we're looking for.
So if we're looking at symptoms, and often with prostate cancer, there are no symptoms, and that's a very big thing to talk about. But then there are also many issues with the prostate that are not cancer related. So when we're looking at urination, frequency or not frequency, difficulty, et cetera, describe some of those issues that men come to you with and ask questions about.
So oftentimes, again, like you said, for prostate cancer itself, a lot of times there's no symptoms. And another thing I'll tell my guys when they'll ask me, well, I don't have any symptoms, I feel fine. And I'll tell them, well, if you have symptoms, it might be too late for us to fix you. Because a lot of times prostate cancer is curable. It's not treatable, it's curable if you catch it early.
And that's something nobody in the cancer world wanted to say decades ago either.
Sure.
They never wanted to use the word cure.
Sure.
There's remission, there's whatever, but I think prostate cancer and colon cancers, and we'll talk about that in a little bit too.
Sure.
The word curable is out there,
Sure.
which is very hopeful.
Sure. But some vague or general symptoms that can develop, sometimes we'll have blood in the urine. Sometimes, every once in a while, we may have a little bit of blood in the ejaculate. That's rare, but every once in a while. And then what we call lower urinary tract symptoms or obstructive symptoms, meaning men that have to kind of push a little bit to pee. Or maybe they're taking a little bit longer to empty. Or maybe they feel when they're done, they don't feel like they're emptying. And so we call that incomplete emptying. The hesitation is when they have to push to pee. Now, these aren't necessarily prostate cancer symptoms, but they're just essential urinary symptoms and can be associated with prostate issues.
And there's and just a gentleman that I know that is older in age and is in his, I want to say 80s now. He said, I feel like I have to go and I get to the bathroom and I don't go. And then I feel like I have to go and I don't go.
Sure.
And so I didn't know what that issue was too. And he says, well, you're a television show girl. What does that mean? I'm like, I really don't know.
Sure.
So when we're looking at all these variable issues, when they come to you, do they just put it out on the table for the most part, or is it that you usually coax it out of them?
In our community, I have to go looking for it. We'll give them a questionnaire when they check in, and it's a symptom score, and it'll ask those questions. But our population is pretty good at denying.
Right.
So I'll sit there and I'll ask them, how are you doing? I'm doing fine. How are your urinary patterns? I feel great. And then I'll start asking, well, how many times a night are you waking up to urinate? Or how often are you going to the restroom during the day? Or one of the key questions that I'll ask them is if I can give you a pill or medicine or something to get you to pee better, would you be interested? And that one kind of opens the door for them as far as knowing that, hey, maybe the way that I'm urinating now is not, or maybe the way I'm urinating now can be better.
Right.
And so a lot of times we do have to kind of coax some of the answers out and let them know that hesitation or pushing to pee or not emptying completely, you may think that's okay, but we might be able to fix that.
Exactly.
Sure.
That's why I love doing this program. And we're going to talk about some sexual issues too. And I said before we started, sometimes it's really good to get uncomfortable when we're here because this is our room. But people who are listening and watching, they're going to pay attention to. It's like, you know what? That's always a question I wanted to ask, but I'm not going to ask anybody that. I'm too embarrassed. So I would really like to get into some of those in a few moments. I want to talk about screening is the wrong word, but to have regular blood tests, to have regular checks of blood pressure, etc., everything that has to do in the cardio world with men. And let's talk about, to your point exactly, those that don't necessarily are in the forefront of saying, well, maybe something's wrong. I'm a man. I can tough this out. What is it that you find yourself as a cardiologist asking men to say, give me the truth about how you're feeling here, high blood pressure. And then there's the question about statins and men, I guess, are more against using statins than women, et cetera, et cetera. So I'm just opening up that gate to however you would like to describe what you deal with every day.
Right. So whenever I see a patient in my clinic who does not have any active heart symptoms and just being referred by primary care doctor for regular heart stuff screening, right? So now then I have to ask so many questions to make sure that I'm covering the most common issues that people of age 40 or above face, So I talk about their blood pressure. How is it at primary care office, whether you check it at home or not, because a lot of people, they don't realize they have MAST or white coat hypertension, and they don't realize until 5-6 years have passed, and now they are coming with kidney injury, right? So that has already done some damage. So there's something we always look for, asking questions about blood pressure, any symptoms related to high blood pressure, for example, headaches, frequent headaches or visual disturbances, any chest pain, any shortness of breath. people of that age, 40 and above, they're high prone for developing diabetes, which is one of the major risk factors for heart disease. So we definitely talk about that too, right?
And you hit the nail on the head. I feel like we talk about diabetes about every other program that we do here. So you mentioned headaches, and that's not something that I commonly associate with high blood pressure.
Right.
So expand a little bit more on that.
Right. So anybody with, so high blood pressure, also known as hypertension, it has several stages, right? So at least 3 stages. So the first stage is not, blood pressure is not super elevated. It's in mildly high range. A lot of people, they don't have symptoms until years have passed by, and then we realize, hey, you have high blood pressure, right? Those people who are in like stage 2 or 3 or very high blood pressure, sometimes we refer them as malignant hypertension. They first time come to the hospital, their blood pressure is elevated in 200s.
Oh my goodness.
And they never had a diagnosis of blood pressure before. So it doesn't happen overnight, right?
So what would their symptoms have been? I mean, say they're coming in with over 200.
Right.
Through the years, their symptoms would have been, as you mentioned,
I'm sure, yeah.
headaches,
Exactly.
just out of breathness.
Yeah.
Okay.
So these people, when you start questioning them, they would say, yeah, I had headaches. I thought it's just migraine or stress related, Yeah, I did have visual problems, but I thought it just, some sort of stress, work-related stress, right? So a lot of, when you take history, you can dig it out and you find that, hey, you're having these symptoms for so long and you just realize that you have high blood pressure.
So I have a question, and I didn't ask either of you this before we got started. So if there's not an answer, there's not an answer. But say there are people that are listening, and to your point, there is not the openness of wanting to tell doctors what's going on. But let's say somebody does not have a primary physician. Somebody maybe doesn't have a clinic, or maybe, and we can talk about the clinics that are around here. If someone thinks, okay, well, maybe I should get something checked out, but they don't know who to go to. I throw that out because it's a pretty common situation here in our community that there isn't a primary care physician. How do you direct folks like that? And let's just say there's, somebody that you met at the grocery store and they recognize you from the show and they're like, hey, doc, where do I go? What do you tell these guys? And it's a hard, and if you can't answer it, that's fine. We will direct, again, the Hospitals of Providence is underwriting this program tonight, and we can talk about that. There are specific male issues. It's a hard question, though. Sure. And it's also the step that they would take to actually make that phone call. And I'm just throwing that out there to either one of you that wants to take it.
No, definitely I can take it.
Okay.
So, I have met a lot of people in hospital who come to hospital for different reasons, and then I've been called to see them for some cardiac reason, and then they tell me, hey, I don't really like to see doctors. I haven't seen doctors in years. And then I educate them about, having to see a primary care doctor and get like common screenings or common health workup done in their office. And they always ask, hey, do you know somebody? And we do have a good network of primary care physicians in El Paso, and many of them are connected with Tenet Healthcare. So we always provide them information, and then they can just make a call and make their appointment there. Yeah.
Nice. I really like hearing that. When we're talking about, I've heard you say, Dr. Tripathi, talk about 40 and over. I'm a whopping 57 years old, so I think, wow, 40, that's young. Yeah. I also often think about, okay, the 50th birthday is when they meaning people everywhere, men, women, start screenings, just start scheduling all their screenings. When we're talking about 40, 45 or 40, you said prostate cancer if they're at high risk, about 55 when they're not high risk. You're talking to age 40 and above with heart issues. When we are talking about heart attacks, I could be wrong, but men and women, if there is a differentiation between the two, I feel like I hear that men have heart attacks more often than women, and or they get them younger. I know you touched base on that earlier. Maybe expand a little bit on that and why that might be. I know it was there's physiological effects, but just in general for the explanation so people can understand that.
Right, yeah. So now we have enough research to say that men are more likely to develop heart attacks at least 10 years earlier compared to females. Okay. Right? And we talked a little bit about it that, estrogen can be cardioprotective in young women who haven't achieved menopause. Some lifestyle, choices that men tend to have more than females, at least, a decade ago, can be contributing factor, and then genetic component as well, right?
And so preventative measures now. So if we know that going in, what are some preventative measures that men can take for that?
So whenever I see a male who is coming to my office for cardiac checkup, I always touch on to see if he's been working on his major risk factors. And so I always ask questions about cholesterol, right? And see if the patient is a candidate for statin, as you mentioned before. And how we do it, it is based on a score called ASCVD score. Okay? So we calculate that, and if your risk is more than 7.5%, we offer them statins.
Okay.
Right? Some people are super hesitant, say, hey, no, I don't believe it. Then we offer them a special test called calcium score.
So let me back up just a smidge. Physiologically, when people take statins, what is that particular medication doing to the system to lower the blood pressure? Again, just so people can visualize what that medication's doing.
So statin is not a blood pressure medication.
Okay.
It's a cholesterol reducing medication.
Okay.
So it works on an enzyme in liver called HMG CoA reductase inhibitor.
So it's enzymes in livers that we're looking at
so
here.
this enzyme is part of cycle that produces cholesterol, bad cholesterol.
Okay.
And it inhibits that enzyme and lowers down the bad cholesterol levels in your blood.
Okay. And that along with eating healthy, but that
Of
really
course, yeah.
does make, I don't know, put the bow on it, I
Right,
guess.
yeah. So that does not replaces, exercise and diet. That supplements it.
Okay.
Yeah. So that's one of the things that's very, very important, right? And that's the only screening test that we offer from cardiology perspective. And then of course we offer diabetes screening, which is not cardiology specific, right? But we talk about that. We talk whether your primary care doctor has checked it. If not, then we order them. And then we always talk about high blood pressure, smoking. These are the 4 major risk factors for heart
we can
problems.
talk about smoking for
Yeah.
a little bit. Let's do that. Let's talk about smoking and diabetes specifically in men.
Right.
Again, our community very high in diabetes. I feel like our community. I worked with the American Cancer Society years ago. Got that smoking ordinance passed. I was called the health Nazi. It was awful, but it was lovely. But at the time, even, and this was back in 2000, so 24 years ago. El Paso had a lower smoking rate than most cities of 500,000 plus in America. And a lot of that was attributed to our Hispanic population. And it wasn't necessarily health reasons. It's because, grandma and grandpa would pop you over the head if you started smoking. So in general, the smoking rates have gone down all across America, all across the world with these smoking ordinances. But when we're looking at El Paso now, I feel like they went down for a long time and then they started creeping back up. And some of it was the e-cigarettes, some of it was the vaping, etc. When you're looking at smoke from a cigarette versus vaping, is that the same type of danger that we can look at when it comes to cardio risk? Or is that, and it could be that the jury's still out on that.
Yeah, so this is my opinion, and we don't have enough data about vaping, honestly. But when you smoke cigarette, you know what you're smoking in, right? You know that you're smoking, tobacco. When you smoke, basically do vaping, you don't know what kind of chemical is going inside your lungs. And we have reports of like acute lung injury leading to death with vaping. So I see a lot of patients in my office and they're like, hey, do you smoke? Yes, but I'm trying to quit. I'm just trying to switch to vaping.
Oh, yeah.
And I always tell
better.
them, please quit smoking, but do not switch to vaping because you don't know what you're inhaling into, you know? So we don't have enough data to say vaping is better than smoking per se, but we don't know what we're smoking in when we vape.
I love that you're saying that because I think that is the common misperception out there. It's like it's not burning smoke, so it's got to be better. And it's not. So thank you for talking about that. All right, let's talk a little bit more about urology. And let's talk about urology. Do you deal with women as well in your practice, women
Yes,
and men urology?
a little bit,
So
yes.
let's talk a little bit about hormones in general, because I think as the population ages, that's something that's always talked about. Again, menopause, woman, I can talk all day, every day. I know a little bit about it because I'm a girl. I don't know anything about testosterone levels.
Sure.
You did, and we joked earlier that the hormone industry is the billion-dollar industry, and it is. You hear about it right and left. You, again, social media, you watch any kind of commercial on TV, you listen to the radio. It's everywhere.
Sure.
Over-testing, under-testing, men over-testing, women just thinking, anything that comes into my place hormone replacement-wise is going to be better. Again, that's another gate. I'm just going to have you open up and describe with the men in your world, how many of them asked you about testosterone testing? What are their myths? What are the realities that you tell them about, etc.?
So percentage-wise, it's not very high.
Mm-hmm.
And part of that is because I don't focus a whole lot on hypogonadism as far as in my specialty.
Mm-hmm.
Meaning, if I get a referral that says low libido
Mm-hmm.
and nothing else, a lot of times I'll tell my staff that probably can go to another urologist that might be more in tune with the various treatment regimens. So if you're an established patient of mine, or if you have other issues and then you bring up the testosterone question, then by all means, I'm all game.
Okay.
And it always starts with my opening question is, how's your libido? How's your sex drive?
Mm-hmm.
And that can sometimes open a can of worms, because you can go down the path of, is it a testosterone issue or is it an erection issue?
Mm-hmm.
Because oftentimes men will have a low libido because they have erectile problems.
Right.
Right. And so it almost becomes a why bother?
Mm-hmm.
Well, I'm not going to be able to perform, so what's the point in trying? I'm not interested. I have low libido.
Right.
Other times it's not. It's erections are fine, but my interest is down.
Mm-hmm.
And so I'll go down the path of ordering the kind of the screening labs, a testosterone panel type of thing.
Mm-hmm.
Looking for total testosterone, free or kind of functional testosterone, and then go from there. And then when that comes back abnormal, then we talk about replacement options, because there's a whole slew of replacement options.
And I do want to get into some of those,
Sure.
because I think that's not often talked about. You
Sure.
just have replacement option and that's it. What I'd like to do right now, and you were great about separating the two. So we've got hormonal issues, which is
Right.
testosterone, and then you've got erectile dysfunction issues.
Correct.
Are those related in any way? And if so, how?
Yes, in the sense that oftentimes a low testosterone level will cause you to have a low or a erectile dysfunction level.
Mm-hmm.
Oftentimes uncontrolled heart disease will cause you to have both.
Mm-hmm.
So to link these two topics on this show, specifically in my young guys, but on all my guys that come in that have erection problems, I will ask them, who's following your cholesterol level? And there's direct correlation between erectile dysfunction and high risk for cardiac disease,
Mm-hmm.
especially in young men. So if I have
When you say young, give me an age group.
40s.
Okay.
Actually, no. I'll have men in their 20s that'll
wow.
come in
Okay.
and they'll have erection issues. And every once in a while, we'll find one that has some abnormalities in their lipid panel and their cholesterol levels.
Okay.
So any of my guys that come in that have erection issues, I make sure that they are in tune, that either it's their heart doctor or their primary care is somebody's following their cholesterol level to make sure that that's getting taken care of.
Mm-hmm.
Because the last thing I want to do is fix their erections and then they have a heart attack
Exactly.
in the process.
Right.
So going back to the link between hormone levels and erection issues, yes, they're connected. So sometimes you'll fix the testosterone level and the erection issue gets better.
Mm-hmm.
And then also vice versa, in the sense that if you fix the erection issue, the libido will get
Increases. As you said, why bother turns into let's bother.
better. They get their mojo back, for lack of
Exactly.
a better phrase.
Mm-hmm.
Sure.
Okay. And when you're looking at, and I would say, or the question would be, what percentage of men, I know we have a different community here, but in general, what percentage of men will come to you and actually be direct with you from the get-go? And I know, again, there's that coaxing thing. It's okay, you've got the questionnaire, we've got these out there.
Yeah.
And I love that cardiology, that you are interlinking all of that,
Absolutely.
that it makes all the difference
Sure.
for a whole body.
I would argue when it comes to erection issues, a lot of my guys, maybe 70, 80%, they're pretty upfront about it. In the
Great.
sense that
Okay.
that they'll have, doc, my erections aren't what they used to be.
Mm-hmm.
A lot of them will kind of hold it till the end of the visit.
Mm-hmm.
And it's mainly because they came in for a PSA or a prostate issue. But also, doc, while I'm here, can we talk about this?
Great. Yeah.
And I'm going to attribute that a lot to the primary care guys. I think the primary care network does a pretty good job with regards to men's issues. And I think they do a good job of starting that conversation. so that by the time they've come to me, they've already spoken to somebody about it. And so they're a little bit more open about the idea of the conversation, and we can make a lot more headway because the taboo of the subject has been kind of erased already.
Exactly. And again, I think too, with this day and age, you just hear a lot more about these things. It's just around you everywhere. And you can look at an algorithm. If somebody has a question, they look something up online, and all of a sudden you're hit with 3 or 4 other hits of, oh, well, he asked about this question. And I just think that's more and more what's happening. On that note, too, there are, just doing this program for years now, there are doctors that have a hard time with, and I respect it, that a patient will come to them with, and it's not papers anymore. Now it's like, here's my phone, and look at all these things I looked up, and this is what's wrong with me, and this is what's wrong with me, because I saw this on the web here, and this guy said this. In general, how do you all deal with that? So when I do research for these programs, I really try to stay in a peer-reviewed type of a website. I use WebMD a lot, but people can't help but just go down these rabbit holes. I'm going to ask about statins, because I feel like that's still a controversy, right? And so people will go down this rabbit hole. This is why it's bad to take statins, and they don't really look at all the stuff that's good about taking statins. So when you have patients coming to you and say, Doc, don't put me on this, don't put me on that, because how is it that you are able to throw realism into their world versus the panic of what they're seeing out there on social media?
Right. So, there's a lot of misinformation about statins on social media, right? So I barely see a patient, not barely, but at least 50% of the patients, when I talk about statin, they have some concerns about side effects, right? So now I have to devote some time explaining them why it is important and what are the risk factors. And when you look at the research, only less than 1% of the people have side effects.
And tell me what those side effects are. So when they're coming to you, what are they expecting? What are the bad things that they're expecting that you're able to debunk?
Right. So some say, hey, my liver will fail. Some say, I'll have muscle pain and joint pains. And that is right. Statins, when you initiate them first, for first few days, you might have mild muscle pain. But if you continue to do that, it will just go away in about a week. Very rarely it can cause serious muscle injury called rhabdomyolysis.
Say that again?
Rhabdomyolysis.
Okay, rhabdomyolysis.
Yeah.
Okay.
But those patients, they start having muscle pain that would not go away, and it becomes very severe that you cannot even lift your foot. So those are something very rare side effects that we talk about, that, hey, this can happen, but it happens in very, very low proportion of patients.
So about 1%?
Less than 1%.
Less than 1%.
Less than 1%.
Okay.
Yeah.
And so when you're looking at and I know we talked a little bit of physiologically what happens, there are enzymes in the liver that are helping bring that cholesterol level. I always think of cholesterol being that golden word. And to your point too, once you are able to get the plumbing system all figured out. Now, there's plumbing here and plumbing there, but in general, when your heart's in good shape and all the soft tissues are in good shape, it just keeps everything else going. So talk about cholesterol and why it's such a big deal to keep your cholesterol under control, whether you have high blood pressure, low blood pressure, etc. And some people are just predisposed to hereditary when it comes to cholesterol. These may be the statin people. There are those that are able to control it with their diets. Talk a little bit about how important it is and why it's so important.
Right. So when you talk about cholesterol, so we have broadly 3 types of cholesterol in our blood. One is bad cholesterol, one is good cholesterol, and one is intermediate cholesterol, right?
Okay. I haven't heard of the intermediate one. I know there's HDL, LDL. What's the intermediate?
And VLDL.
Oh.
We don't really focus on VLDL and HDL. We really talk about LDL when we talk about bad cholesterol.
Right.
Right? So what this bad cholesterol does is that it captures different cells in your body and basically accumulates in the layers of your blood vessel and develops plaque in blood vessels of your heart. And not only it develops plaque inside blood vessels of heart, if it remains uncontrolled for several years, it can develop into periphery as well, including blood vessels that are supplying genitals. And when you engage into sexual activity, because there's a blockage, you'll have erectile dysfunction because you're not receiving enough blood in there, right?
Okay.
So that's why it is very important that you control your, not just from sexual standpoint, but from heart standpoint as well, because if you don't control it, you'll keep building those plaques inside blood vessels. And eventually, when it's more than 70%, typically what we look for, you'll start having symptoms. And those symptoms are chest pain,
So it takes
shortness
up to
of breath.
70% until you start having
Yeah.
symptoms.
Yeah, your body's very forgiving.
Goodness.
If you develop 50%, probably you're still okay. 60% probably okay. When you develop 70% and more, then your body says, hey, you need to stop and start taking statins.
Right. Oh my gosh. So we were talking about no symptoms earlier.
Yeah.
And this is where it becomes important to, and I'm throwing this out there too, and I don't know, for a woman, every year you have the date that you go get your pap smear, you have your mammogram, that's done. Do men in general, different community, I get it, have that yearly check? Is that something that is becoming more common? Is that still not common in general? How does that work? I mean, again, the girls do it one way. I don't know about the guys. I feel like it's not. Colonoscopy, it's a perfect time to bring that up because I feel like after the age of, maybe that's the one that went down to 45.
The colonoscopies are
That's
in
what it
40s
was.
now.
Okay, so the colonoscopy was at 50, and so now the screening is asking at 45. Maybe that's the one screening that with that particular doc, you've got your gastroenterologist, maybe that's going to become the primary doc if people are really following that yearly colonoscopy. And maybe talk a little bit about screenings there since we were talking about screenings with you earlier.
So I try to keep most of my guys on a once a year.
Great. Okay.
And you don't necessarily have to check the prostate every year. You can get a prostate exam every 2 years if you're low risk, completely normal exam. But what I will do is get a PSA, the blood test, about once a year.
Okay, good.
And that's the main way that I'll screen is once I get them in, once I figure out their kind of risks, stratify them, and get a baseline, and then we just kind of go from there. But for the most part, if you're a compliant patient, male patient in my practice, you're coming by at least once a year so I can make sure that we're on cruise control, make sure everything's working good.
I hope that becomes more the case because I know with colonoscopy, if you have no issues and there are no polyps, you wait for 10 years until you have the next one. If you have a polyp, it's removed, even if it was benign, then it's 5 years. That's still 5 long years, though.
You forget.
You do. You forget, and who's going to be around to say, oh, and that's one of those questions, too. Every time we go to the doctor, there's the questionnaire. When was your last colonoscopy? And I, for the life of me, I'm kind of fibbing. Like, well, I think it was before COVID. I'm not sure. Maybe. No, that's right. It was after. And so you start having these markers of when all that starts happening. We are at 20 minutes, and I still have some questions here, but I want to make sure because when we're talking about male health, I know we have a cardiologist on board and we have a urologist on board. What are some of the things that we haven't talked about yet that we can really get into? Again, cardiology, we talked a little bit about diabetes. I don't know if we want to go more into that. I feel like we sort of should. Are there more men that suffer with diabetes than women in general? Or do we know?
I mean, I don't really deal with managing diabetes, but
Okay.
as far as my knowledge is concerned, it's equally distributed in male and females.
Okay.
Yeah. I don't think males are more affected than females.
Okay.
Yeah.
And so let's talk about specifically with diabetes and cardiology, however, because there are so many things that are affected. We talk about wound care, but we also talk about just healing and the soft tissues. What does diabetes affect when it comes to soft tissues, when it comes to arteries, veins, et cetera? What are the complications there?
Right. So as I told you before, diabetes causes vascular dysfunction. Basically, it affects almost every organ in your body, right? Including blood vessels. So it causes microvascular dysfunction, and eventually it leads to progression of plaque formation. Along with high cholesterol, those people with diabetes, they are more likely to develop those plaques inside blood vessels, and eventually they get heart attacks sooner or earlier than person who does not have diabetes.
Okay.
Yeah, it's all about function of endothelium in the blood vessels that it interferes with.
Okay.
Yeah.
I do want to talk a little bit more about prostate cancers. We were talking specifically about prostates and some of the issues that could be related to prostate. But now if we're looking at the PSA level, and Dr. Uranus, you talked about what a normal level is. And there are baseline levels. And for some men, I know that they can hover at a certain, even an elevated PSA, but as long as it doesn't change for 4, 5, 6 years, that's still okay. It's kind of that watchful waiting is what they called it,
Sure.
and then observation.
Mm-hmm.
So a PSA level at what level does it have to be at for you to be a little bit concerned?
So I think that if you were to ask 3 urologists, you might get 3 different answers.
Okay.
And I would argue that it's based on where you train. Where I trained, where I did fellowship, where I grew up basically for urology, our cutoff was 2.5.
Okay.
And that's low. A lot of primary care providers like to use 4.0 as their threshold for concern, but that's kind of an outdated number. But where I did my fellowship at 2.5 and above, we started having the conversation of an elevated PSA.
Okay. And that's usually in the person's 50s. So does age make a difference there? Will like 4.0 be okay if you're like
If
70?
you're in your 70s, sure.
Okay.
And so there's a what's considered an age-related PSA level.
Okay.
Also, kind of an older thought process, but still very, very usable, very, very valid. But yes, the older we get, the higher the risk of developing prostate cancer. And there's nothing we can do about that. We're going to age.
Mm-hmm.
So all we can do is try to catch it early. The best results with regards to prostate cancer are the ones that are caught early.
Mm-hmm.
And that goes back to the theory or the thought that under certain circumstances will cure you. But a lot of it is luck in the sense that we got to catch it early.
Right.
So when I get a patient that comes in and has an elevated PSA, I'll start letting them know the options. And there's a whole bunch of different options: genetic studies, X-ray studies, and then the good old-fashioned biopsy.
Mm-hmm.
Then once we figure out a game plan, and it entails the lab results, it entails their family history, their risk stratification, then it entails their exam.
Mm-hmm.
And I give them all that information, and I tell them it's dealer's choice. It's patient's decision. There's oftentimes no right or wrong answer. And if they want to watch it, we'll watch it. But I might keep them on a shorter follow-up regimen of maybe every 3 months, maybe in 6 weeks.
Mm-hmm.
And then once we figure out what their baseline is, then we can start extending the office visits. Your PSA is never the same value. It goes up and down every day.
That's something else I learned about the last time we did a prostate cancer show. I was not aware of that. And correct me if I'm wrong, but I believe it said if you had sex that morning, if you ejaculated that morning, your PSA number is going to be a little bit different than if it was a month ago.
Potentially, yes.
You know, just I think they talked about exercising, what the level of heat or coldness is. And explain some of that, because I think I can't remember who I had on, but they were talking about if you're going to go have your PSA done, then take these factors into consideration when you get your number back, especially if you are a person who's watching it.
Sure.
So talk about some of the things that do affect your level.
So a urinary tract infection can make your PSA bump up sometimes. So if you're having burning when you urinate, or just maybe you're just not peeing right, then maybe wait a little bit to get your PSA checked. Ejaculation could potentially skew your PSA number a little bit. Overtly physical activity. So if you're a physically active person on a regular basis and you keep your same regimen, you're going to be fine. But if you're a 5-mile-a-day runner and the day before you get your blood test, you go and run 10 miles, you may have strained the system and your PSA may bump up a little bit. And so it's just a matter of whatever your activity is baseline, keep your baseline activity. Don't pick the day before you get your PSA drawn to work extra hard, or obviously sometimes you have to. But if you can avoid it and just keep the same activity, then your PSA should still fall within a fairly normal range.
Okay.
But yeah, it's going to go up and down every day.
And that's something, again, I'm embarrassed I didn't know that, doing this show for all these years and doing prostate at least once or twice a year. When you're looking at that too, a baseline, and I know you mentioned it could be every 3 months, could be every 6 months. What level, and again, you're a 2.5 guy, but let's say somebody hovers around 10 and has been hovering around 10 for years, but it stays at around 10. Is that a concern issue, or is that like, this is your baseline? How often would you check the PSA then? And maybe this is a person that gets checked every 6 months just because it is elevated, but nothing ever changes.
So if your PSA is 10, that's high, and that makes me nervous. So I'll examine you. Let's say we do the exam and it's totally normal. Okay, that's a good start. but I'm still nervous.
Okay.
So I might get some genetic studies done. There are some DNA tests, some genetic studies that can risk stratify us. There's an MRI. We can get an MRI of the prostate, look for nodules, for lesions that brighten up on the MRI. So I'll probably do that. And if all of that comes back normal, low risk, it's never normal, but if it all comes back low risk, then we'll say, okay, your PSA is 10.
Okay.
And if it remains at 10, we're good. But I'm going to see you fairly regularly because I don't want to miss that day that it bumps up to 15. Hopefully never will.
Right.
But if it does, I'm not going to miss it.
So here's the hard question, and I feel like I'm leaving cardiology out of the boat for a little bit, but the hard question is, but it's great. There are so many different options to treat prostate cancer.
Yes.
Once you have, and let's say this person who has a 10 finally did a biopsy, and now there's a couple of cells in there that are like, you know what, this is a cancer now. This is a malignancy. From there, and I know every person's different. Age matters, what their physical condition is, etc. In general, how would you prefer to treat prostate cancer? And you can just throw a case study out there, because I know you can't just pick an ideology and go with it. But.
So the conversation starts with how aggressive is your cancer, grade 1 through 5, right? And that's based on what's called the Gleason score, which is based off of a pathologist many years ago looked at thousands of samples and gave a grading on the abnormality of the architecture. But now to make it a little bit easier, it's grade 1 through 5. So if you're grade 1, the options are going to be we can watch it or we can treat it. All right, and then the treatment, you can take it out with surgery or you can radiate it. If you're a grade 5, we're probably not going to want to watch it. And so it just falls within those between 1, 2, 3, 4, or 5. If you're a 1 or a 2, I'll give you the option of observation, but I'll also give you the options of treatment. If you're a grade 3, 4, or 5, I'm here for you guys. I tell my guys, you're an adult.
Yeah.
You're in control of your healthcare. I'm here for you.
I know I'd be the guy. It's like, okay, doc, what do you think though?
Right.
Because I don't know. So I'm going to ask you, what do you want?
I'll tell them I don't like observation for a 3 or 4 or 5, grade 3, grade 4, grade 5. It's just, I think we're playing with fire. And then depending on the age, I'll tell them, usually there's no one treatment better than the other. So I'll tell them that. If you look at statistics I try to base my practice based off of statistics and not anecdotal evidence or my own experience. And I'll tell them, usually radiation versus surgery, there's no one option better than the other. And so you have to go with the little voice in your head. What does the little voice in your head tell you is going to be better for you at this time? What side effects here,
what side effects there?
Right.
Okay.
And then they'll ask me, well, what would you do? If I was your brother, if I was your dad, what would you do?
Right. The question every doctor gets.
And I'll tell them, I'm a surgeon. I do what I do because I think surgery fixes problems. And so my opinion is biased. And I do the same thing. In your case, statistically speaking, you might do better with surgery. Or in your case, statistically speaking, surgery, radiation, they both work well. So from a cancer treatment standpoint, you're probably going to do fine either way. You got to go with what the little voice in your head says and what the team says. I always try to get my guys to bring family in the room. Right. Not their entire family, which has happened.
Again, you're looking at this community, we're going to have 50 of us in the room.
And so, but, the significant other. And what does the team think is the best treatment option for you? And I tell them, we don't know the future. I don't know what's going to happen in 6 months or in 16 years. And so I don't know if you're going to have side effects. Statistically speaking, you might have this, this, and this. What I don't want to hear is I don't want my guys coming into my office and say, man, I had surgery, I should have had radiation.
Yeah.
And I don't want them to say that. What I want them to say is, even though I'm having these issues, when I made the decision, I made what I thought was the best choice for me at that time. Because that's all we got is the data that's in front of us, the options that are in front of us. And then we always need a little bit of luck. Yeah. Doesn't matter how great we are as far as physicians. We need a little bit of luck. We need the body to help us with regards to recovering and just overall repairing itself.
Right. I like the way you said that too, because I'd like to talk a little bit about prevention if we can. We hear again a lot about diet and exercise, whatever. But it does matter. And as a cardiologist, as a person who deals with anytime your heart is better, everything else that you're faced with in your body is going to do a little bit better. So when you have, I don't know if you ever have clinics or if you have people that come talk to you, it's like, Doc, what can I do in general to make my health better? And you're going to say diet and exercise. I get it. But if you can be specific about that, and maybe that's an age-related thing. You talk about people in their 40s that are weekend warriors. I'm still one in my 50s and I hurt myself and dang it, but it's better than doing nothing. Maybe that's right in my head. But in general, what is it you tell men to try to keep themselves healthy? It seems such a generic question, but...
Right. Yeah. So, whenever somebody asks me this question, I try to understand their background, because a lot of the risk factors that we deal with for heart problems, they're genetic. And high blood pressure, high cholesterol, diabetes all have genetic predisposition. So if somebody comes to me and he asks about what should I do to reduce my chances, I try to ask him, do you have any family history? Do you have any high risk behavior, for example, smoking, doing drugs or alcohol? And if person has family history and high risk behavior, I go more aggressive on them. They need to do more than a person who does not have these risk factors, right? If somebody has family history of premature cardiac heart disease, somebody in family died of heart attack at age of 40, they need to do more. They need to do, change their lifestyle completely. They need to have frequent checkups, and maybe they need some injectable medications now that those are available. So it all depends on what are the risk factor a person has. But of course, as you said, diet, lifestyle changes do not replace anything. Somebody needs to do it more than others, but these are the basics.
Kind of look at what your background is.
Yeah.
So when you said injectable medications, tell me what you mean by that.
So, there's an entity called familial hypercholesterolemia. Right. So basically there's defect in an enzyme, and that will raise your bad cholesterol in hundreds to thousands. And those people we have seen that those people die in their 30s, 40s with massive heart attack.
Oh my goodness.
It's all because of genetic mutation. So now we have a medication called PCSK9 inhibitor.
Okay, say that slower.
PCSK9 inhibitor. So that PCSK9 is an enzyme.
Okay.
Right? So basically this medication inhibits this and lowers down the cholesterol.
Okay.
Okay. And we can prevent, early premature heart attacks in these people with these medications.
Now, I have to tell you, I'm not very familiar about this. So how long has this been something that is out there? Is it something that's still relatively new? Am I just not hearing about this?
No, it's been a couple of years.
Okay.
First of all, it's very expensive medication.
Okay.
And second,
you said it's injectable. So
it's injectable twice a month.
Twice a month. So you have a shot that either you go in or you do at home twice a month.
Right.
I am not familiar with this at all.
Yeah.
Okay,
this is not
keep going.
commonly used. Yeah, this is not very commonly used.
Okay.
We use them either in these people who have family history of premature heart condition and they actually have familial hypercholesterolemia, or those people who are not tolerating statins and their bad cholesterol is still high.
Okay.
So then we use these options. These are big guns, very expensive.
So when you say that, and again, I really try to stay away from insurance when I talk to the physicians because I don't think it's fair. But in general, when you're talking about high costs, I guess that there might be when you apply to be the guy that insurance might cover that. Is that something that is even in this game? And I'm thinking about this with bariatric surgery, for example. It is considered elective to most insurance companies until it becomes a comorbidity. Is that something that sort of works in the same situation here?
Yeah, it does. Yeah, we get a lot of trouble getting these medications for our patients, because 99% of the times it gets rejected in first try. Then we have to give them more evidence that, hey, we tried statin and he has this side effect and he really needs it for his heart. Basically, you have to go back and forth, and most of the times we're able to get it, but it takes time.
Okay.
Yeah.
And is this a type of injection medication that they're on then for the rest of their lives? Does this take, a couple of years and it starts bringing down cholesterol?
Usually the rest of their lives.
Usually the rest of their lives.
Yeah.
Okay. So here, I'm just trying to follow up with this because it's new, and I will, after this show, go and do some research on this. So you're talking about men in their 30s and 40s. So this is something that is genetically that is just present in general. Since this is a male health show, do you find that that's more common in men than in women? I think in cholesterol situations in general, I hear more about that with men than in women, for a lot of the reasons that you were stating earlier.
No, so it's a autosomal dominant disease, so it has nothing to do with sex. So it's
Nothing
not
whatsoever.
sex-linked disease. Yeah, so it's commonly seen in both
Okay.
men and women. Yeah.
Okay. We did not talk about hormone replacement, though, in prostate cancer, which could be another option. And since we are talking about hormones in general, is that still a pretty common practice for prostate cancers that aren't too advanced to try estrogen to do some hormone treatment?
Hormone androgen deprivation is what it is. Removing the testosterone from the body
Okay.
is usually reserved for high grade. Again, going back to grades 1 through 5, it's the grade 4, the grade 5 prostate cancer. And oftentimes it'll be used in combination with radiation, or sometimes it'll be used isolated. And basically, we're basically giving the patients male menopause. We're getting rid of their testosterone level.
Okay.
And so it can, long term, can have some pretty significant side effects, increasing your risk for diabetes, increasing your risk for heart disease, increasing your risk for bone disease, things of that nature. And so very rarely is it the first line therapy,
Okay.
but it's still out there, sure.
Okay. I want to thank you both for being here. Again, we've had Dr. Tripathi and Dr. Renes, cardiology and urology, and this has been Tenet Healthcare with the Hospitals of Providence, underwriting the show, and we've been talking about the male health issues that we have. And we hear a lot about women's health these days, and I think that's just a rah-rah. But I think that we should never forget about all of our men in our lives going to the doctor. So if you have watched the show and you would like to watch it again, or if there are shows that we have done in the past that you'd like to go watch again, there are 3 different platforms that you can do that. One is pbselpaso.org, and you can find the El Paso Physician logo on there. There's also the El Paso County Medical Society website, and that's epcms.com. And then there's youtube.com. And with YouTube, you have to actually type in the words, the El Paso Physician. And the great thing about all 3 of those platforms is you can watch this program and you can go back and watch all the programs that we've done, when I say all, the last couple of years. And if you can find a topic in there that you're interested in, you can do that as well. Also, if you have a question that you'd like to ask the El Paso County Medical Society, you can do that by emailing them, and we will try to either get back to you on the show, or you will have a doctor emailing you back the answer to your question. And that is epmedsoc at AOL.com. Again, mail your questions to epmedsoc at AOL.com. This has been Men's Health Month, and this is the El Paso Physician. I'm Catherine Berg, and thanks for watching.
Good evening. I am Dr. Allison Days, a past president of the El Paso County Medical Society. The El Paso County Medical Society has put on the El Paso Physician TV program for the last 26 years in conjunction with some of our local healthcare partners. Topics over the years have included colon and breast cancers, healthy lifestyle issues, vaccines, and many, many more. These programs are archived on kcostv.org, epcms.com, and on YouTube. You may access the programs at any time on these websites. If you have questions on tonight's topic, please reach out to epmedsoc at AOL.com, and we will try to get your questions answered in a timely manner by an expert in the field. This program showcases local specialists, and it is with great pride that we are able to present this educational opportunity to you every month. A big thanks goes out from the Society to all of our specialists who have been able to give their time as speakers on this program, and to the El Paso community members who have welcomed us into their lives for all of these years. Thank you again for tuning into the El Paso Physician tonight.